Okay, thank you, Dr. Kelly, Dr. Chan, for two really fantastic lectures. They are both of our experts are here with us now, and we're going to jump right into the Q&A. So, Dr. Chan, we'll start with you. So one of the questions here is about tapering. So when do you taper, either whether you do PPI, steroids, do dupilumab for maintenance? From BID or higher doses? Do you do it at 6 weeks, symptoms, or what is your time frame for how you start to taper?
Yeah, there's currently really no guidelines on how we taper and how soon we taper. I usually try to make sure that the patient has maintained symptom and histological remission first. I usually start tapering at least, keep them on the same dose for at least 6 months before I start thinking about tapering. So usually make sure that I leave them on for a long time and not tapering too quickly.
Okay, great. So is there a role for steroid drug holidays for patients with EOE, similar to kids with asthma? We try to reduce steroid risks and patient outcome concerns.
There, we do not currently recommend that. All patients for EOE should be on maintenance therapy if you're able to taper into a lower dose. The problem is that a lot of times they can have recurrence of the disease before they start having symptoms. So what you don't want is for them to start having inflammatory changes and start developing fibrostenosis and not know about it because they're not having symptoms initially. So we currently don't recommend any sort of treatment holidays, but keeping patients on maintenance therapy. Hopefully, in the future, we'll have better markers that will allow us to tailor therapy that way.
Okay, great. Thank you. Dr. Kelly, so in a patient who has a negative IgA TTG, Marsh 3B, small bowel biopsies, and positive for DQ2, testing for CVID is negative, and biopsies after being taken off ARBs were the same. So could this be celiac disease?
Well, yes, it could be. It could be seronegative celiac disease, which occurs in perhaps 5 or 10% of patients with celiac disease. But there are other causes of villus atrophy. And when the TTG is negative, that's really when we start to think about those other causes. So they were listed in my talk, but they include conditions such as Crohn's disease, peptic duodenitis, autoimmune enteropathy. And really, the first step is to have the biopsies evaluated by an expert gastropathologist to see if there are hints as to other diagnoses other than celiac disease on the biopsies. The other step to take is to check for HLA DQ2, DQ8, because if DQ2, DQ8 is negative, then one can say that this is almost certainly non-celiac villus atrophy, and one can look more carefully for the other diagnoses.
Great. A management question here. Dr. Kelly, do you recommend routine vaccination against pneumococcal and meningococcal disease due to
Yes.
hyposplenism in celiac?
Yes, I do indeed, because of hyposplenism. The frequency of hyposplenism is not very well characterized, in fact, in patients with celiac disease, but there's no doubt that hyposplenism does occur, and so I recommend vaccination.
Okay, great. Dr. Chan, are you using Dupixent more now? Are you using it more frequently and earlier in the course of disease? And how do you decide who you would put on Dupixent first?
Yeah, there's always this discussion of sort of a bottom-up versus a top-down approach. Currently, all 4 treatment options for EOE are considered similar, and I usually offer them and discuss this with a patient early on, even when they're first diagnosed. Obviously, there's always the issue of coverage for dupilumab, especially early on if they haven't tried any therapy yet. I have been using it more upfront, especially if they're covered. Most insurance would cover it as long as the patient failed one type of therapy. The type of patients that I generally would push something like dupilumab a little bit more are patients who have other atopic conditions, other type 2 inflammatory conditions. So patients who also have things like asthma and other conditions are the ones that generally may suggest dupilumab more. The other thing to consider is convenience and compliance. A lot of patients have difficulty doing daily steroids, kind of mixing them every day and trying to use them every day. So those are some of the patients that might benefit from a weekly injection instead.
Okay, great. And then there's just another treatment related question. Do you use topical steroids alone for maintenance of EOE or always in conjunction with a PPI?
I do use them alone if if patients achieve histologic and symptom remission with steroid alone. There have been some small studies that have shown that for patients who don't fully respond to steroid, if you add PPI to it, they may then achieve a remission. But if they are in remission with just steroid alone, I don't generally add the PPI.
Okay, great. So Dr. Kelly, do you have celiac patients who have persistent elevations of TTG antibody despite a strict gluten-free diet and a repeat endoscopy that shows normal duodenal biopsies and patients are feeling well? And clearly they seem to be on a true gluten-free diet. And is this then an incidental positive, false positive TTG or not?
There's no doubt this happens. Most patients will drop their TTG on a gluten-free diet, but some do not. And my approach is just as the questioner suggests. My approach is to do a small bowel biopsy and determine whether or not the TTG elevation is incidental or whether it actually reflects ongoing disease activity. And quite often, the biopsy will be normal.
Okay, and then sort of kind of a related question that just came through is, so if a patient who remains TTG positive and biopsy positive, but they have no symptoms, what would you do?
Well, if there was an effective intervention, I would use it, but there isn't. And so I would not use steroids for that situation. I would just follow the patient.
Okay, great. Dr. Chan, about dupilumab, how long do you keep patients on dupilumab?
I actually keep them on indefinitely, similar to other maintenance therapy that we do for other treatments.
Okay. And then do you always confirm histologic remission? And if so, how many weeks after starting therapy?
I always, and that's actually key, you always should confirm histological remission. It's very frequent that patients have symptom improvement, but no improvement or inadequate improvement in histology. So the goal is to have improvement and resolution in both. Usually I do follow-up biopsies about 8 to 12 weeks after initiating therapy.
Okay, and then just this last follow-up there related to that is there reason to check endoscopy and EOE after someone's been asymptomatic and responding well to prevent fibrostenotic disease?
That is something that there's no current agreement on, and there's no specific guidelines on. Many providers do. I generally do endoscopy, every couple years, at least in these patients, even if they've been on remission. There are sometimes, as I talked about earlier, patients who start having symptoms, who start having inflammations and some changes coming back, but their symptoms are not coming back yet. So that's something that we need more data on, whether or not that's an effective and efficient way of doing it. But currently, I personally would do follow-up endoscopy about every couple of years or so.
Okay. So Dr. Kelly, how do you approach liver abnormalities that may be associated with celiac disease?
Well, they're very common, particularly early on in the disease course when there's active inflammation. It's quite common to have minor elevations of AST and ALT. I evaluate the patient after they've been on the gluten-free diet for 6 months to see if the liver abnormalities have resolved or not. And if they have not, then I would evaluate them as I would in a patient who does not have celiac disease, bearing in mind that some autoimmune liver diseases are more common in celiac disease, such as autoimmune hepatitis or primary biliary cirrhosis.
Okay, great. Dr. Chan, if a patient has failed PPI, is failing steroids, and dupilumab is not an option due to cost, How would you proceed if elimination diet has also failed?
Yeah, those are the challenging patients, but there have been some emerging data on combination therapy. So I would start doing these treatment in combination, PPI with steroids, for example, PPI with diet. There have been some very small case series on even steroid in some patients who are on elimination diet. So basically, you start trying to do a little bit of a combination therapy. Not a lot of definitive data on that, but in those challenging patients, that will be one option.
Okay, Dr. Kelly, do you have a recommendation about oats, patients with celiac?
Well, I think oats are generally intrinsically safe in most patients with celiac disease. There are a small number of patients that appear to react against oats. The bigger issue with oats is that the supply of oats may not be gluten-free, and there may be contamination of the oats either in the field or when it's transported to the facility or during processing. And so a lot of um, food products that contain oats are contaminated by gluten. And that's really where if a celiac patient is to take oats, they should have the oats from a certified gluten-free source.
Okay. And so, Dr. Kelly, there are a couple questions here related to sort of, long-term follow-up in celiac. Let's say someone, it's sorted out, they're symptomatically good, their TTG is negative. What else do you need to do? And can that be done by a primary care doctor, just referred back, or what else needs to happen?
I think yes, they could be followed by a primary care physician who could monitor their TTG periodically, maybe once every year or every 2 years, and evaluate how they were doing on the diet. But I find that most primary care physicians have very little familiarity with celiac disease, and so they prefer that they be followed by a specialist.
And in terms of, like, as you were saying, so long-term management, let's say you continue to follow them, you're just monitoring symptoms and TTG primarily.
Correct, yes. There is a question as regards whether we should be routinely doing follow-up biopsies. In some centers, follow-up biopsies routinely done after the patient has been on a gluten-free diet for 2 or 3 years. In other centers, it's only done if there's persisting positive TTG or persisting symptoms despite the gluten-free diet for 2 or 3 years. So
Okay.
there's some variation in practice there.
Okay, great. Dr. Chan, if someone is already on a PPI and esophageal biopsies show less than 15 EOs per high power field, could they have still EOE with just a partial response to the PPI?
It could, and that's why it's important that if you're trying to diagnose EOE, you should ask patients to come off of PPI before you do the initial endoscopy.
Okay, great. Dr. Kelly, when and if do you ever screen for lymphoma in patients who have had a diagnosis of celiac?
There's no recommendation for screening for malignancy in patients with celiac disease other than the routine regular screening for the general population. I guess one reason or two reasons not to screen for lymphoma is that a selection bias will mean that you're generally going to be screening patients who are adherent to a gluten-free diet. And so the risk of lymphoma is less. The second and sad situation is that when you find lymphoma, it's not easy to treat. And so there isn't a lot of gain in making an earlier diagnosis.
Okay, great. And Dr. Chan, when do you decide to dilate for EOE?
Generally, if there's high-grade stricture, also if patients are symptomatic and you see stricture, even though if they're lower grade, usually you want to target to be at least about 16 millimeter within the esophagus. So if it's smaller than that and the patient is symptomatic, that's when you would consider dilating.
Okay, and maybe I'll end with this last one about elemental diet. Like, is that something that you need to go to a dietitian? Is there a way to order it? How do you get it covered?
Yeah, I generally have the patient see a dietitian for that. It's extremely rare that an adult can do it for a prolonged period of time. But usually the nutritionist or dietitian will have resources for these patients. And once they've made a recommendation, usually those are the ones that you can prescribe. There is a newer formulation that are coming out that it's a little bit more palatable, but generally it's really hard for adults to be compliant with that.
Okay. All right. Oh wait, let me just there are a couple quick here. So Dr. Kelly, so there's a question about here. It's recommended that patients undergo repeat EGD 2 years following diagnosis to assess healing, question mark. The AJH celiac guidelines are unclear.
Yeah, they're unclear because there's difference in practice there. And some specialist centers will routinely do a follow-up biopsy after 2 to 3 years, but others will only do it if there are other indications. And that's why the guideline is vague on that point.
Okay. Okay. Well, on that note, then I will end the session. And I want to thank Dr. Kelly, Dr. Chan for a really amazing session here. We will now move into our break. So we did go over, but I think you have some time here for lunch. We'll come back at 1:30. So we'll see you then.